Hi everybody, welcome back to my channel. My name is CSM and this is another segment of PharmRescue Cardiovascular Drugs Part 1. If you haven't checked out the first video on GI drugs, don't forget to check it out. If you have, I hope you found it helpful. So, also before I go into today's topic, don't forget to check out my PharmRescue page on Instagram where I post information, questions and other interesting things. So today, we'll be talking about cardiovascular drugs, which is a very huge topic. So it's going to be part 1 and part 2. I hope you find it really helpful. Don't forget to make notes, pause it when you need to, enlarge the screen when you need to, zoom in when you need to as well. So cardiovascular drugs, what comes to mind when you hear about it? Yeah, I think about the heart. I think about blood pressure. I think about atrial fibrillation, arteries, anticoagulants, ACE inhibitors, different parts of the heart, supraventricular tachycardias. I think about bleeding as well. Loads of things to think about on the cardiovascular drugs, so let's just get started. Amiodarone. So it's one of those drugs that you definitely need to learn. How does it work? It's a class 3 antiarrhythmic drug that works primarily by blocking the potassium rectifier current responsible for repolarization. What's repolarization? It's basically when the cell membrane is positive, so there are more potassium ions let into the cell membrane. So the indication is treatment of arrhythmias when other drugs are ineffective. Ventricular tachycardia or pulseless ventricular tachycardia. So contraindication is avoid in sinus node disease unless pacemaker is fitted, and sinus bradycardia and thyroid dysfunction. We would look at the reason in a minute. So the side effects include hepatic disorder, hyperthyroidism, skin reactions, nausea, arrhythmias, respiratory disorders. For hepatic disorder, ways you can recognize when that occurs is pale stool, yellowing of the skin and the eyes, itchiness, nausea and vomiting, tenderness of the tummy as well. Hyperthyroidism and hypothyroidism, can you differentiate it? Personally, when I see hyperthyroidism, I think of overactiveness. Someone is hyper, someone is very active. So overactiveness, I tend to match it together with loss of weight. And hypo, I tend to match it with tiredness. I tend to match it with increase in weight. I've been overweight. Hypo is also matched with low metabolism rate. Side effect for the information: stop corneal microdeposit. So if you see some sort of discoloration in the patient's eye and the patient is on amiodarone, then you can flag up the fact that the person probably suffering from corneal microdeposit. Thyroid function, so for hyperthyroidism, you stop it. For hypothyroidism, you treat it with levothyroxine. Hepatotoxicity, the same way you can recognize the symptoms are, and signs and symptoms are yellowing of the skin, itchiness, yellowing of the eyes, nausea and vomiting as well. Pulmonary toxicity, so coughing, sore throat, and the likes. Shortness of breath as well. Chest pain. So it's a lot to take in, but when you see monitoring requirement, think side effects. So from the side effects, you can see or you can sort of tell the kind of thing you're to monitor in a patient, or the kind of parameters, that's the word, that you monitor in a patient on amiodarone. So just from the top of my head, I would think thyroid function, yeah, chest x-rays, liver function, etc. So monitoring requirements: thyroid levels before treatment and every 6 months. Just so you remember, T3 is usually high, but note T4 may be raised in the absence of hyperthyroidism. Therefore, T3, T4, and thyroid stimulating hormones should be measured. This is very important because you can see in an exam and they say, what is the patient suffering from? But you see the T4 is raised, or the parameters they give you, T4 is raised, T3 is high. So just make sure if you see it in an exam, you make sure you look at T3, T4, and TSH to see the levels. So don't just rush and say, oh yeah, T4 is high, so obviously that means the person is suffering from hyperthyroidism. So for thyroid levels, for amiodarone, you measure T3, T4, and TSH. Chest X-ray, liver function before treatment, and then every 6 months. Potassium levels before treatment. With IV, make sure you do the ECG monitoring, and resuscitation facilities must be available. Then monitor liver transaminases closely as well. Important safety information: avoid concomitant treatments with certain antiviral medicines. You hardly see these medicines in the pharmacy or being prescribed, but it's just important to know. So Fosbuvir and Daclizivir, I might not be pronouncing it properly, but that's the spelling of it. Patient monitored if taking antivirals and those at risk of bradycardia. But what's bradycardia? Bradycardia is reduced heart rate. Monitored closely for the next 2 days, 48 hours after starting concomitant treatment with those antivirals. So those people at risk of bradycardia should be closely monitored for the first 48 hours if they're being treated with antiviral and amiodarone. Dose adjustment for simvastatin and dabigatran. For simvastatin, the dose is usually 20 milligrams, and for dabigatran, the dose is 110 milligrams twice daily. Patient and carer advice: phototoxic reaction. Shield from the sun during and after treatment. This is very important to know. So the patient and the carer, make sure you advise them that amiodarone is a phototoxic drug, meaning that it is likely to cause a phototoxic reaction when the patient is exposed to the sun, similar to doxycycline. So shield from the sun during and after treatment. How to recognize signs of bradycardia if taking amiodarone with sofosbuvir, Simpravir, and Daclizivir. You get what I'm talking about. But basically, bradycardia, shortness of breath still, chest pain, and dizziness. One of those are a few signs that you can look out for in patients taking amiodarone and the antivirals just listed. The dose of amiodarone is very important to know, and to also to know. Treatment of arrhythmias when other drugs are ineffective or contraindicated. Notes: amiodarone is used when other drugs are ineffective or contraindicated. So 200 milligrams 3 times a day for 1 week, 200 milligrams 2 times a day for the further week, and 200 milligrams once a day as the maintenance dose. So an easy way you can use to remember is 3, 2, 1. And so the 3 is for week 1, the 2 is for a further week, so that's the week 2, and the 1 is for the week 3 and above, so the maintenance dose. 200 milligrams once a day as maintenance dose, or the minimum dose required to control arrhythmias. Adenosine, how does it work? Binds to AV nodes of the A1 receptor. Indication: rapid reversion to sinus rhythm or paroxysmal supraventricular tachycardia. Contraindication: asthma, COPD, second or third AV block, and in hypotension. Caution: QT interval prolongation, recent MI, severe heart failure. Side effects: obviously from the contraindication you can tell the side effects: abdominal discomfort, chest pain, hence the reason why it's contraindicated in COPD and asthma. So headache and flushing, that's the side effect of adenosine. So this is the stop and reports slide for adenosine. So bradycardia, chest discomfort, chest pain, hypertension, especially if it's severe. So just know that if a patient presents with any of the signs or symptoms and they're on adenosine, stop and report. Digoxin, everyone's favorite drug, I believe, in terms of exams and testing. How does it work? It's a cardiac glycoside. Indication: controls ventricular response in persistent and permanent AF and arterial flutter. Contraindication: second degree AV block, SVT, arrhythmias, that is supraventricular arrhythmias, and those associated with accessory conducting pathways. Caution: hyperkalemia, hypokalemia, and hypomagnesia. Why is this a caution? In a few slides you will know why. So some other caution include hypoxia, recent MI, and severe respiratory disease. Side effects include cardiac conduction disorder, vision disorder, skin reactions, vomiting, nausea, and cerebral impairment. Unwanted effects depend on the concentration of digoxin and the sensitivity of the myocardium. Just note that. Those for arterial fibrillation is 125 to 250 micrograms daily. For heart failure is half of it, that's 62.5 microgram to 125 microgram. This is important to know. So the dose for AF is 125 to 250 and heart failure is 62.5 to 125 micrograms. A quick way to remember it is heart failure half, so half the dose of AF. Those adjustment is necessary in the elderly due to the narrow therapeutic index of digoxin. It's necessary to monitor plasma digoxin concentration in renal impairments. Why? Because digoxin is renally excreted. So in a renally impaired patient, then the excretion is affected. Blood should be taken at least 6 hours after a dose. Monitor serum electrolytes and renal function. Why? Due to toxicity. As we saw in the previous slide, caution is hypercalcemia, hypokalemia, and hypomagnesia, as well as hypoxia. All these factors, if a patient has it, can lead to the high risk of digoxin toxicity. Also, on digoxin toxicity, it's important to know those drugs that cause hypercalcemia, hyperkalemia, and hypomagnesia. Under the GI, I mentioned omeprazole, which causes hypomagnesia. So it's very important to take note of that when the patient's on long-term omeprazole, and also on digoxin, because it can increase the risk of digoxin toxicity. Same as if in an exam situation you're given a list of drugs that cause hyperkalemia or hypocalcemia, and you notice that the patient is on digoxin and you see the levels of their potassium quite high, and you know what to flag up or what would be the reason for the patient to be experiencing some signs and symptoms of digoxin toxicity. The likelihood of toxicity increases progressively through the range of 1.5 microgram to 3 micrograms per liter. If toxicity is suspected, withdraw. So what are the signs of toxicity? Yellow vision, confusion, nausea and vomiting, and skin reactions. Antiplatelets, what comes to mind? Most people say aspirin, and that's right. Apart from aspirin, you have clopidogrel, dipyridamole. I think about blood thinners, bruising, bleeding. Aspirin, how does it work? Blocks the formation of thromboxane 2 in the platelets and also acts as a COX-2 inhibitor. Indication: cardiovascular disease, unstable angina, NSTEMI, acute ischemic stroke, arterial fibrillation, that's AF, following coronary bypass surgery, and mild to moderate pain. So that mild to moderate pain is as a result of blocking COX-2 inhibitor. Then for thromboxane 2 is as leads to, that's why it's used in cardiovascular disease, in unstable angina, acute ischemic stroke, because it prevents the formation of a clot from platelets. So contraindication: active peptic ulcer, bleeding disorders, that's the antiplatelet dose, Ray's syndrome, so for children under 16 years it's contraindicated, previous peptic ulceration. Caution in asthma: avoid during fever or viral infection in children, and uncontrolled hypertension also should be used with caution in the elderly. Side effects: dyspepsia and hemorrhage. Pregnancy, so divided into two parts, so that's antiplatelet dose and the analgesic dose. For the antiplatelet dose, It should be used with caution during the third trimester due to the risk of developing impaired platelet function and risk of hemorrhage. Delayed onset and increased duration of labor with increased blood loss. Avoid analgesic doses if possible in the last few weeks. Low doses are probably safe. High doses may be related to intrauterine growth restriction, teratogenic effects, closure of fetal ductus arteriosus in utero, and possibly persistent pulmonary hypertension of the newborn. I know that's a lot to take on, but just to summarize, the antiplatelet dose is responsible for risk of hemorrhage and delayed onset and increased duration of labor, while the analgesic dose can lead to pulmonary hypertension of the newborn. These are important points you can take out of that. So aspirin is used in pregnancy for prevention of preeclampsia in women at moderate or high risk. So women at moderate or high risk of preeclampsia. The dose is 75 milligrams to 150 milligrams daily. So usually the aspirin comes in 75 milligrams, that's low dose aspirin. So either one tablet or two tablets daily from 12 weeks gestation until the birth of the baby. In breastfeeding, it's advised to avoid. Allergy, so NSAIDs, cross sensitivity, those management of unstable angina and STEMI, 300 milligrams chewed or dispersed in water, suspected transient ischemic attack, 300 milligrams once daily until diagnosis established. Used for the long-term treatment of TIA in combination with dipyridamole and in acute ischemic stroke, and also in ischemic stroke not associated with AF in combination with dipyridamole if clopidogrel is contraindicated or not tolerated. The dose is 75 milligrams once daily. So allergy, as stated previously, is NSAIDs cross-sensitivity. Those continued, so ischemic stroke not associated with AF, used alone if clopidogrel and dipyridamole is contraindicated or not tolerated. So that's 75 milligrams. If you can recall that clopidogrel and dipyridamole are antiplatelets used in ischemic stroke, and aspirin can be used. Next dose and indication is AF following a disabling ischemic stroke before being considered for anticoagulant treatment. So the dose is 300 milligrams daily for 14 days. So this is the dose you give a patient that's just waiting to be considered for your anticoagulants such as Apixaban, Riboroxyban, Warfarin, and the likes. So the dose is slightly high. So that's 300 milligrams daily for 14 days. Mild to moderate pain and pyrexia. The dose used is 300 to 900 milligrams, 4 to 6 hours as required, and a maximum dose of 4 grams per day. Clopidogrel, how does it work? It's a prodrug of a platelet inhibitor. That is, it prevents platelets from sticking together, thereby preventing harmful clots from forming. Indication, prevention of atherothrombotic events in PCI, adjunct with aspirin, in patients not already on aspirin, and in peripheral arterial disease. Prevention of atherothrombotic event in acute MI with and without ST segment elevation. CIA for patients hypersensitive to aspirin. So in patients hypersensitive to aspirin, they are prescribed clopidogrel. Prevention of atherothrombotic and thromboembolic events in patients with AF and at least one risk factor for a vascular event with aspirin. So these are the indications of clopidogrel. So there are about 4 that I've listed here. So your contraindication for clopidogrel is active bleeding, caution, discontinue 7 days before elective surgery if antiplatelet effects is not desirable. Side effects include diarrhea, hemorrhage, GI discomfort, and skin reactions. An important interaction that I should state is clopidogrel and omeprazole. It's predicted to decrease the efficacy of clopidogrel, that's omeprazole, so it's advisable to avoid. I've seen in the pharmacy that patients are prescribed omeprazole or lansoprazole with clopidogrel, so maybe advise the patient to take omeprazole a few hours before taking clopidogrel so that it's long cleared out of your system before clopidogrel is taken. So let's look at the dose. Prevention of atherothrombotic events in PCI adjunct with aspirin in patients not already on clopidogrel and in peripheral arterial disease. Loading dose of 300 milligrams prior to procedure, alternatively 600 milligrams. Prevention of atherothrombotic events in STEMI, adults 18 to 75 years, initially 300 milligrams, then 75 milligrams for at least 4 weeks. For adults 76 years and over, 75 milligrams for at least 4 weeks. Prevention of atherothrombotic events in acute MI without ST segment elevation, initially 300 milligrams, then 75 milligrams for up to 12 months. As you can see, for atherothrombotic event in STEMI, it's for at least 4 weeks, while for that with acute MI without ST segment elevation, it's for about 12 months. Also to point out that for adults 76 years and over, you start them off with just the low dose. That's for prevention of atherothrombic events in STEMI. So going over to the fourth one, that's TIA and acute ischemic stroke for patients hypersensitive to aspirin 75 milligrams once daily. And finally, for the prevention of atherothrombotic and thromboembolic events in patients with AF and at least one risk factor for a vascular event with aspirin is 75 milligrams once daily. Anticoagulants. What comes to mind? I'll give you a few minutes or a few seconds. Yeah, me personally, I think about Warfarin. I think about proton beam time. I think about factor XA inhibitors. I think about Riboroxyban, Apixaban. I think about hemorrhage. I think about AF. So many things you can literally scribble around anticoagulants in general. So the first one we'll be looking at is dabigatran. How does it work? It's a direct thrombin inhibitor with rapid onset of action. You need to remember rapid onset of action in the next couple of slides, so please take note of that. Dabigatran has the rapid onset of action. Indication, treatment and prophylaxis, that's prevention of DVT and PE, prophylaxis of stroke and systemic embolism in non-valvular AF. Contraindication, so kidney clearance of less than 30 ml per minute, active bleeding, significant risk of bleeding, elevated liver enzyme, people taking potent enzyme inhibitors such as ketoconazole. Side effects include diarrhea, dyspepsia, GI bleeding, nosebleeds, and nausea. Hopefully you can see a sort of pattern with the side effects listed. So very important advice, seeing the side effect, is do not take over-the-counter OTC NSAIDs. Why is that our business? So obviously patient comes to the pharmacy and asks to buy some aspirin, asks to buy ibuprofen. It's very important to ask them what medication they're on, because NSAIDs increase the risk of bleeding, as you can see listed on the aspirin as an example. So if a patient is taking dabigatran and also comes in to buy OTC NSAID, then the risk of bleeding is increased more. Anticoagulant effects reduces 12 to 24 hours after last dose is taken. Therefore, it is important to take dabigatran as directed. A reversal agent for dabigatran, so if a patient takes excessive dose of dabigatran, or if the effect is needed to be reversed, the drug given is idarucizumab. So idarucizumab, it's a monoclonal antibody. Carry Pradaxa patient alerts card at all times. Prescribing information. So do not prescribe to people with creatinine clearance less than 30 ml per minute, with active bleeding, hepatic impairment, and elevated liver enzymes, as previously mentioned. That's why such parameters need to be figured out or measured before starting treatment with dabigatran. So it's a lot to take on, but we'll get there. So make sure you're watching this in an expanded sort of frame so that it's clear enough. So the dose for prophylaxis of stroke and systemic embolism in NVF is 150 milligrams twice daily. Reduce dose to 110 milligrams twice a day if person is EAR. That's the acronym that I've put together. So elderly, over 80 years, that's E. At high risk of bleeding, that's A, and receiving concomitant treatment with verapamil or amiodarone, and that's R. If you remember in amiodarone, there's need for dose adjustment while taking simvastatin and amiodarone, dabigatran and amiodarone. So the dose for that reduced dose to 110 milligrams twice daily if person is on verapamil or amiodarone. So the treatment of DVT and PE is just the same as above, but for at least 5 days. I made it this way because it's a lot on NICE guidelines to sort of read the same thing over again. So just remember, treatment of DVT and PE is same as above, but for at least 5 days. For the prevention of VTE in people who have undergone hip or knee replacement surgery is 220 milligrams once daily, initiated within 1 to 4 hours of completed surgery with 110 milligrams. So the initiation dose is 110 milligrams within 1 to 4 hours of completed surgery, then 220 milligrams once daily thereafter. Reduce dose to 150 milligrams once daily, initiated 1 to 4 hours of completed surgery with 75 milligrams, and continued with 150 milligrams once daily thereafter for people with RAM. What does RAM stand for? So receiving concomitant treatment with verapamil or amiodarone. A, aged 75 and above. M, moderate renal impairment with a creatinine clearance of 30 to 50 ml per minute. So for the reductions, for stroke prophylaxis is EAR, and for prophylaxis of VTE is RAM. So for dabigatran, the dose for those with renal impairment, less than 30 ml per minute, don't. 30 to 50 ml per minute, adjust. 50 to 80 ml per minute, no problem. So don't adjust, no problem. So for patients with less than 30 ml per minute renal clearance, do not give them. For patients with 30 to 50 ml per minute renal clearance, adjust the dose. And for patients with 50 to 80 ml per minute, there is no problem at all. Go ahead and give them the usual dose. How would you remember? Think stroke EAR 80 110 milligrams BD and VTE RAM 75 150 milligrams OD. Refer to the previous slides for it to make sense. Apixaban, probably many doctors or prescribers' favorite. How does it work? As a factor XA inhibitor, indication includes prophylaxis of VTE, recurrent VTE, treatment of PE and DVT, prophylaxis of stroke and systemic embolism in NVF. Contraindication, active bleeding, and risk factors of major bleeding. What are the risk factors? Example, severe hypertension, stroke, ischemic stroke, TIAs, GI bleeding, GI ulcers, etc. So Apixaban should be used with caution in those with high risk of bleeding. Side effects include nausea and vomiting, skin reaction, anemia, and hemorrhage. So the dose for prophylaxis of stroke and systemic embolism in non-valvular atrial fibrillation, that's NVAF, the usual dose of Apixaban is 5 milligrams 2 times daily. But remember ABC in regards to reduction of the dose. So that's age, 80 years or over, body weight 60 kilograms or less, creatinine 1.5 milligrams per dl or 133 micromole per liters or more. So that ABC is the reason why you should reduce the dose of Apixaban from 500 milligrams 2 times a day to 2.5 milligrams 2 times a day, usually. For treatment of DVT and PE, 10 milligrams twice daily for the first 7 days, maximum daily dose of 20 milligrams, followed by 5 milligrams twice daily. The maximum daily dose of 10 milligrams. How can you remember this? So for treatment of DVT and PE, you start high with 10 milligrams twice daily for the first 7 days, then you reduce for the maintenance dose to 5 milligrams twice daily. I think that's self-explanatory. Prevention of recurrent DVT and PE in adults following completion of 6 months treatment of DVT or PE. So you've treated it, now you want to prevent the recurrence of it. So the dose is 2.5 milligrams twice daily, maximum daily dose of 5 milligrams. So 2.5 milligrams is recommended dose for prevention, while the treatment recommended dose, that's the maintenance, is 5 milligrams twice daily. It's easy to remember it if you sort of put 1 and 2 together, or sort of read the top one, read the second one, and you see the pattern between them, if that helps. So for hip or knee replacement surgery, 2.5 milligrams twice daily to be started 12 to 24 hours after surgery. Prescribing and dispensing information. Duration of treatment is determined by balancing the benefits of treatment with the risk of bleeding. So in general, you wouldn't just memorize it and think one code fits all. So the shorter duration of treatment, at least 3 months, should be based on transient risk factors. Patients should be given and carry their card at all times. Do not prescribe to people with creatinine clearance of less than 15 ml per minute, active bleeding, or prosthetic heart valve. Monitoring requirements. Regular renal function tests are required as approximately 30% of Apixaban is excreted renally. Riboroxyban. How does it work? It's a direct inhibitor of activated factor X, factor XA. Indication: prophylaxis of VTE following knee and hip replacement surgery, and prophylaxis of PE and initial treatment of DVT and PE. Contraindication: recent brain surgery, recent GI ulcer, previous stroke, TIA, etc. Caution: severe hypertension, vascular retinopathy, and those taking enzyme inhibitors. We would list them shortly. Side effects include GI discomfort, abdominal cramps, anemia, dizziness, diarrhea, constipation, hemorrhage, and fever. And just to point out as well that due to the fact Riboroxyban causes GI discomfort, it's advisable to advise your patients to take Riboroxyban with or after food. That's actually the cautionary label. When you're printing out your dispensing label, you would notice that that's one of the cautionary labels added to your dispensing label. So for pre-regs watching this, this is usually one of those questions they like to ask on the Riboroxyban. So prophylaxis of stroke and systemic embolism in NBAF, 20 milligrams once a day. Dose adjustment required in patients with creatinine clearance 15 to 49 ml per minute, reduced to 15 milligrams once daily. Treatment and prophylaxis of DVT and PE, and the prophylaxis of recurrent DVT and PE, 15 milligrams twice daily for 3 weeks, followed thereafter by 20 milligrams OD. One of the questions I've come across is a patient has been on Riboroxyban for 21 days on a dose of 15 milligrams. For the maintenance dose, which of the following is the maintenance dose? That sort of question. And it's 20 milligrams once daily. Dose adjustments. In person with creatinine clearance 15 to 49 ml per minute, the dose stays the same, but consider reducing to 15 milligrams once daily if risk of bleeding outweighs risk of recurrent DVT or PE. And as stated under the prevention of stroke and systemic embolism, that's the first point in this slide. Those adjustment is required when creatinine clearance is 15 to 49 ml per minute, and it should be reduced to 15 milligrams once daily as stated. For prophylaxis of atherothrombotic events in adults following an acute coronary syndrome or with coronary heart disease, the dose is 2.5 milligrams twice daily in combination with aspirin or with aspirin plus clopidogrel. Usual duration of treatment is 12 months. It's important to know dose adjustment stays the same, but caution if creatinine clearance is 15 to 29 ml per minute for people with renal impairment. Less than 15 ml per minute, do not give Riboroxyban. Monitoring requirements. No routine anticoagulant monitoring required. Monitor for signs of bleeding and stop if severe bleeding occurs. I have placed warfarin by itself and I'm asking what comes to mind. Warfarin is that drug. Basically, it has loads of things that you need to learn, it has loads of things you need to remember, loads of counseling, and loads of targets. So these are the things that should come to mind when you see warfarin. So the INR, switching from warfarin to another anticoagulant, bleeding, hemorrhage, etc. And also, very important, the colors, the strengths of warfarin tablets. Warfarin, how does it work? Competitively inhibits vitamin K epoxide reductase complex, one essential for activating vitamin K. Remember this because it's important when we get to the slide for counseling, the slide for diet and lifestyle advices. So strength and colors, that's the strength and color. If you can see it, I would ask that you maximize your screen so that you see it properly. So 0.5 milligrams is usually white, 1 milligrams brown, 3 milligrams blue, and 5 milligrams pink. Indication: prophylaxis of embolization in rheumatic heart disease and AF, prophylaxis after insertion of prosthetic heart valve, prophylaxis and treatment of VTE and PE, and TIA. Contraindication: avoid use within 48 hours postpartum and within 72 hours of surgery. Hemorrhagic stroke is contraindicated in hemorrhagic stroke and significant bleeding. Caution for the information elderly. So prescription potentially inappropriate, so that's the stop criteria, with concurrent significantly bleeding risk such as severe hypertension. Prescription potentially inappropriate as part of drug therapy with antiplatelet agent with patients with stable coronary, CVVD, or PAD without a clear indication for anticoagulant therapy. What does that mean? Basically, do not use it as a dual therapy. In those cases, it must have a clear indication. A clear indication of warfarin must be identified before giving it to a patient on dual therapy. In simpler terms, I hope that makes sense. So, it's inappropriate for first DVT without continuing provoking risk factors for no longer than 6 months. For first pulmonary embolism without continuing risk factors. So basically, prescription is potentially inappropriate in patients that is just their first DVT, experiencing their first DVT, experiencing their first pulmonary embolism without continuing risk factors. Warfarin interaction, enzyme inhibitors, enzyme inducers, that's what you need to think about. So talking about enzyme inhibitors enhances the effects. How does this happen? Example of an enzyme inhibitor, sertraline, so SSRIs. So when they block the enzyme responsible for breaking down warfarin, that means there's more warfarin available to interact effect, and so it enhances the effect of warfarin, so increases the iron arrow. That means there'll be an increased risk of bleeding, if that makes sense. For enzyme inducers, example, phenytoin, phenobarbital. So when they bind to the enzyme responsible for breaking down warfarin, there is less warfarin available in circulation because they induce the enzyme more available for warfarin to bind to. So there's less warfarin available in circulation, if that makes sense. So it reduces the effects of warfarin, and so reduces the iron arrow and reduce risk of bleeding, but increase risk of forming a clot. So according to NICE guidelines, iron arrow checks timeline inhibitors. If prescribing a drug that may interact, consider checking iron arrow 3 to 5 days after, except can't, so that's corticosteroids, azoles, NSAIDs, which takes about you have to take about 4 to 7 days, tamoxifen 1 to 2 weeks, and thyroxine 1 week. Examples of other inhibitors. Then the next one is reduction of effects timeline. So how long does it take for the reduction of the effects by an enzyme inducer lasts? How long does it persist after it reduces the effect of warfarin? For inducers, PPR, that's phenobarbital stroke primodane, 2 to 4 days, and it may persist for about 6 weeks. Phenytoin persists about 6 weeks, rifampicin 5 to 7 days, and persists about 5 weeks. So other examples of enzyme inducers include tricyclic antidepressants, that's TCAs, St. John's wort, rifampicin, carbamazepine, and griseofulvin, as well as vitamin K containing vitamin complexes. So what are the side effects of warfarin? Common side effects include diarrhea, jaundice, skin necrosis, pyrexia, pancreatitis, hemorrhage, and with the frequency not known, blue toe syndrome. Conception and contraception. Women of childbearing age should be warned of the danger of tetragenicity. So in pregnancy, warfarin should not be given within the first and third trimester. Warfarin crosses the placenta with risk of congenital malformations and placental, fetal, or neonatal hemorrhage. Also, it's advisable to stop warfarin before the 6th week of gestation due to the risk of fetal abnormality. Starting those when warfarin therapy is initiated. For rapid anticoagulation, 5 milligrams or 10 milligrams once a day for 2 days, and we measure iron arrow on day 3. Why? For warfarin, it takes about 72 hours to get the full effect, so that's why it's advisable to check the iron arrow on day 3, because by then the warfarin is broken down and you can get the best result. So subsequent dosage depends on PT time, reported as INR. So PT stands for prothrombin time, reported as INR. So for immediate effects, low molecular weight heparin plus warfarin. So low molecular weight heparin has a rapid response compared to warfarin. So before the warfarin kicks in, you can place the patient on a low molecular weight heparin, then in addition to warfarin before it kicks in on the 3rd day, if that makes sense. So lower initiation dose of 5 milligram is advisable in the elderly, for those anorexic, those with hepatic dysfunction, or those at high risk of bleeding, example in severe uncontrolled hypertension, GI disorders, so GI bleeding like ulcers. Then patients with AF, no need to achieve rapidly, so slow loading regimen is safe and effective. So warfarin 1 milligram or 2 milligrams. Warfarin taken and should be taken at the same time of day, and it's advisable for warfarin to be taken at the same time of day. Like we stated earlier, maintenance dose depends on INR. Average maintenance dose of warfarin is 5 milligrams, usually taken at the same time every day. Do not forget. daily dose may lie between 1 milligrams to 15 milligrams, and to aid compliance, it's advisable to use the fewest number of tablets each day. So when prescribing to your patients, make sure the fewest number of tablets each day, because patients find it easier to swallow less tablets than giving them much or more tablets to swallow. So constant daily dosing, not alternate dosing. Some dosing regimen for warfarin is usually every other day or on alternate days, and that can be confusing. So it's safer to give your patient constant daily dosing. And also, lastly, avoid halves. So that's why there's a 0.5 milligram dose, so the patient can easily be prescribed 0.5 milligram and be given a 0.5 milligram tablet instead of being tasked with the task of cutting the tablets in half. Stop before surgery. So like we know, warfarin is an anticoagulant, and for patients taking anticoagulant and needs to go to surgery, they're at high risk of bleeding. So it's either wise to stop the warfarin or reduce the dose. But we'll take a look at that in a bit of detail now. For general surgery, you may need to stop temporarily, but you need to check INR before surgery. And if INR is greater than 1.5, administer phytomenadione. That's vitamin K, which obviously helps the clotting, um, helps the blood clot faster. So stop 5 days before planned surgery. If INR is less than 1.5, you need to continue. Resumed at the normal dose on the evening of surgery. So if you had to stop warfarin for the whole 5 days before surgery, it can be resumed at the normal dose on the evening of the surgery. That's after checking the INR. So the INR is checked on the day of the surgery. For dental procedures, it's not a massive surgery. Usually no need, but may need to temporarily stop it or reduce the dose. So INR is checked 72 hours before dental surgery. Risk of bleeding with stable INR within 2 to 4 is small. So a patient with a stable INR, the risk of bleeding is low, but is increased risk of thrombosis. So because your warfarin is reduced or stopped during dental procedures, there's increased risk of thrombosis if anticoagulants are temporarily discontinued. So this slide I tagged 5 hemorrhage circles, stop 4, withhold 1. What does this mean? In these 5 circles, you see that in the first 4 circles, you stop warfarin, and in the final circle, that's the 5th circle, you withhold or reduce warfarin. I would explain it in details shortly. Circle 1, major bleeding. You give the patient prothrombin complex. That's factor 2, 7, 9, and 10, or plasma. And phytomenadione, that's vitamin K1. So circle 2, high INR greater than 8 with minor bleeding. You give the patient phytomenadione via slow IV. Circle 3, with an INR 5 to 8 with minor bleeding, you also give the patient phytomenadione via slow IV. For circle 4, high INR greater than 8 but no bleeding, still 8, that's still high but there's no blood, so you give the patient phytomenadione but orally. And the final circle, circle 5, INR 5 to 8, no bleeding, you withhold or reduce warfarin. So that's why the slide is titled 5 hemorrhage circles, stop 4, withhold 1. Hopefully this is easy to remember, but if you have your way of remembering this sort of slide easily, I'm happy for you to go ahead with it, and please feel free to share it in the comments section below. MHRA warning. Calciphylaxis is a rare condition but very serious if and when it occurs. Appropriate treatment should be started if diagnosed and stopping warfarin considered. Most likely observed in patients with end-stage renal disease. Seek urgent medical advice if a painful skin rash develops. Duration of treatment with warfarin. For people with DVT and PE, the rule is 636L. What does that mean? So 6 is weeks, 3 months, 6 months, L long term. We look at it in detail. 6 weeks for distal DVT, cough VT, 3 months for proximal DVT or PE where there are known temporary risk factors and there is considered to be a low risk of recurrence. 6 months for proximal DVT due to unknown causes, so idiopathic causes. Long term, if there have been recurrent DVT or PE and mechanical prosthetic heart valve. I wouldn't advise you to cram it, but try and understand and remember it. So 6 weeks distal, 3 months proximal P. So how you can remember is 6 distal. Distal in the letter alphabet is D. The fourth letter. P is way down the line. So 3 months is longer and P is obviously way down the line. So 3 months for proximal DVT, 6 months for proximal DVT due to unknown causes. So it's lesser for temporary risk factors and where there is low risk of recurrence, but 6 months proximal, but when there are unknown causes, then long term when there is a high chance of recurrence and also mechanical prosthetic valve. Hopefully I've not confused you, but I'm just trying to make it simpler and easier for you to remember in an exam setting. You may have your way, but that's my way. So INR targets, INR 2.5 for VTE, antiphospholipid syndrome, AF, that's atrial fibrillation, cardiovascular. Higher targets can be used in this case for cardiovascular, such as 3, bioprosthetics and bioprothesis. INR 3.5 for recurrent VTE. For recurrent VTE, one have to remember is you want their blood to be runny, like increased INR, more runny because they're at high risk of thrombosis or forming a clot because they've had the VTE before. So you want the target to be a bit higher than those having it for the first time, if that makes sense. Mechanical prosthetics, aortic valve, INR of about 3 is allowed, and mitral valve 3.5. Warfarin to this, switching from warfarin to dabigatran, apixaban, Riboroxyban, and Digoxin. Stop treatment and measure INR. You don't just want to stop warfarin and switch over to the next anticoagulant without measuring INR. So ideal INR of 2 before starting there. INR less than 2, then you can start treatment with there. If between 2 and 2.5, starts there the next day. So between 2 and 2.5 is slightly high, and so you start there the next day. If INR is greater than 2.5, that's higher risk of bleeding. Wait until INR drops to below 2 before starting there, if that makes sense. Just try and think about it. You don't want to switch from warfarin to there when the INR is high. You want to switch when it's a bit low, a bit manageable. That's INR of 2 before starting there. If it's between 2 and 2.5, start the next day. Notes: time taken for INR to reach less than 2 will differ from person to person. Always remember, it's the patient you're treating, not the statistic. There to warfarin. So switching from there to warfarin as dabigatran, apixaban, Riboroxyban, edoxaban to warfarin. There except E, that's the first bullet point. Edoxaban has a special case we would look at shortly. So dabigatran, apixaban, Riboroxyban. First of all, start treatment with warfarin. Do not stop DAR. Why? This is because warfarin takes about 3 days to get the full effect. So if you stop dabigatran or apixaban or Riboroxyban before starting warfarin or once you're about to start warfarin, the patient is at risk of thrombosis or forming a clot. So you do not stop DAR before starting warfarin treatment. Prescribe warfarin and DAR concomitantly until the person's INR is at the target range. I've just explained why. Once INR in target range, stop treatment with DAR or DARE. So DARE without E or DAR. So E to warfarin, that's Digoxin to warfarin, half that E. So 60 milligrams to 30 milligrams once daily when taken or when you're about to start warfarin, or 30 milligrams to 15 milligrams once daily with warfarin. Both prescribed concomitantly until INR at target range, then E stopped. Measure INR at least 3 times prior to taking daily dose of Riboroxyban during the first 14 days of concomitant therapy. I hope that's not too much to take in, but try and understand it or try and memorize it, but don't bombard your head with information. After stopping there, so that's dabigatran, apixaban, riboroxyban, and the digoxin, what next? Remember, you started warfarin before stopping there, so measure the patient's INR after 24 hours to ensure adequate anticoagulation. Monitor the person's INR closely once a week in the first month of warfarin treatment until 3 consecutive INR values are achieved, usually between 2 to 3. So warfarin monitoring requirements: daily or alternate days till INR of 2, 2.5 or 3 on 2 consecutive occasions, then longer intervals twice weekly for 1 to 2 weeks, then once weekly depending on response and stability, then every 12 weeks, more frequently in at-risk groups. Patient and carer advice. For patients and carers, it's very important to give them diet advice, lifestyle advice. So diet changes, so vitamin K, alcohol, and pomegranate juice. Those are things that you should advise them about. So things containing vitamin K, broccoli, green leaf vegetables. Anticoagulant booklet is needed and necessary, should be issued to all patients and carers, which includes and contain advice for patients on anticoagulant treatment, an alert card to be carried by the patients at all times, and a section for recording of INR results and dosage information. So everybody, that's everything for today. I know it's been a lot to take on, but I hope you found it helpful. Don't forget to like, subscribe, comment, and share. Until next time, my name is Ambc and this is Top 100 Drugs with PharmRescue. Don't forget to like, subscribe, share, and comment. Until next time, my name is Ambc and this is PharmRescue.